Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. Usually the first Wednesday of the month is when we air my favorite show, Show Me the Science. But today, we have a bonus Show Me the Science thanks to the availability of today's very special guest. I am extra happy today because our very special guest is U.S. Senator Roger Marshall. Or shall we say, Dr. Senator Roger Marshall, who represents the state of Kansas in Washington, D.C. Doc Hawk joins me today at the desk as usual. And like us, as we mentioned, Senator Marshall is an outstanding physician. He practiced obstetrics and gynecology in the state of Kansas for 25 years. Senator, thank you for joining us live from Washington this morning. You have a special interest today, I think, in our topic. Thanks for being here. Today, we're talking about a topic near and dear to all of our hearts, and that's bugs. And I'm not just talking about bugs in the heart. We're talking about superbugs. And superbugs are very resistant bacteria that is resistant to different antibiotics. And we're not talking about the little creatures with legs. These are often one or two-celled organisms that are in our bodies and are causing infections. Well, since this is an educational program dedicated to the science, let me explain some of the differences. In the medical world, a bug is a general term for any organism that can cause an infection in humans. Bacteria, viruses, SARS-CoV-2, parasites, fungi, and others. Superbugs are strains that are resistant to most and sometimes all of the antibiotics and other medications commonly used to treat infections that they cause. A few examples of superbugs include resistant bacteria that can cause pneumonia, some forms of Staph aureus, some kinds of Pseudomonas, some kinds of things that cause urinary tract infections as well as in skin infections. The challenge we have is that more of these bacteria are becoming resistant to common antibiotics. We're going to talk a little bit about that and why, as well as the pipeline of new antibiotic drugs, which is unfortunately slowed to a trickle. So first, what's an antibiotic? Well, antibiotics are a type of medicine that kill or stop the growth of bacteria. They often inhibit during the reproductive phase of a bacteria, or they do something that kills the bacteria in some other way. Some examples of antibiotics: penicillin, ciprofloxacin, Keflex, erythromycin, a Z-Pak. What does it mean to be when bacteria are resistant to antibiotics? Simply put, it means the antibiotics fail to really work to kill off the bacteria to prevent them from growing. And the reason we have that is because we've had so many antibiotics, we tend to use them a lot in medicine. Some would say we may even overuse them because we seem to tend to sometimes treat viruses which don't respond to antibiotics. We use them so much, we've selected for resistant bacteria. Senator, this is certainly a public health crisis. And first, let me say thank you for being one of the standard bearers who help us take this issue on. For those of us who have to treat a lot of patients like Hawkeye and I, this is a really big deal. I treat patients with cystic fibrosis. They have Pseudomonas. Pseudomonas can be very resistant. And we've lost patients due to the resistance of the bacteria they have. The general public, though, doesn't hear much about this. Why do you think that is?
Hey, well, good morning, Dr. Stites. It's great to be with you and put my stethoscope back on.
I was going to say, I love that stethoscope, man. That's great. That's a good look. You should do that more often.
We had to look for it up here, but I keep one handy just in case. But it's great to be back with you and with my friends from KU Med Center as well. But, I kind of given up on why or what makes something sexy in this world. But what I've found is the best thing we can do is to tell a story. And I think just for your listeners, think about penicillin. It was developed in the 1920s. It was very effective against gram-positive organisms like staph and strep. But through the years, it's been used, and bacteria are smart. They replicate at such a quick fashion that eventually they develop a resistance to that particular antibiotic. So in my own practice, one of the most common infections I saw was bladder infections and kidney infections. Those are both some of the leading causes of maternal morbidity and mortality, as well as a cause of preterm labor. And what we saw in my 25-year practice, delivering a baby most every day, is that maybe starting off, the bladder infections, kidney infections had 10% resistance to ampicillin, to the point where it was probably 30%. So 30% of those bladder kidney infections resistant to ampicillin. So fortunately, we always stayed a step ahead, and we had something else we could treat those folks with. And I think the same thing can be said for, like you said, people with cystic fibrosis get recurrent lung infections, pneumonias, and so for some reason Pseudomonas develops a strong resistance. I can even think back to one more story. My son's was playing football, a state-ranked team, and we had an outbreak of methicillin-resistant Staph aureus, MRSA, as it would be called as well. And we thought it was related to maybe some of the little fine granulars in the turf that were causing erosions on the skin. So, again, it took a special antibiotic to do that. Again, it's not sexy. It's not a single shot like HIV or just one or a cancer. But boy, Dr. Stites, you said you've seen people die from a resistant bacteria before, and that must just be grueling to sit there and watch someone slowly die when if you just had that medicine to cure them.
It totally is. I remember very well when a local principal here had a really resistant form of a bacterial one called Burkholderia spacia in CF, and I just remember sitting on the side of the bed, and they know everything going on around them. They just can't breathe, and their lungs are full of this mucus. He said, "I don't want to die." It's like, I got nothing. I can't help you. I mean, it's a truly helpless feeling, and your life can change on a dime once you get one of these superbugs, and you don't even know that it's coming. We have some alarming numbers to share with our audience today. Each year, 2.8 million Americans acquire a serious infection caused by antibiotic-resistant bacteria. As a result, 35,000 Americans die. Globally, that number rises to over 1.3 million, which led the World Health Organization designating antibiotic resistance as a top global public health threat. According to a study in The Lancet, antimicrobial resistance killed more people in 2019 than HIV and malaria. So, Senator, you're leading an effort to do something about this. And first, let me just explain to the audience a little bit. And Senator, I want you to weigh in here. It feels a little like the reason that pharmaceuticals have not spent as much in this space to help develop new therapies is partly because their return on that investment isn't as great. I mean, you look at some of the new biologics and what's being charged on a new CF drug that's saving lots of lives, but it's $300,000 a year. Antibiotics aren't quite that much. Talk to us a little bit of what you see as the causes in the market. Why aren't we seeing these new drugs, and what can we do about it?
Yeah, well, Dr. Stites, I think it's relatively simple to think about this. If you develop a new drug for diabetes or, say, for obesity, the opportunity to prescribe that drug on a daily basis for tens of millions of patients, there's certainly a large return on investment. Versus the medicines that you and I are talking about today, I'm hoping you don't have to use them. And if you do, maybe you'll use it for 7 or 10
Sparingly.
days.
Yep.
So we're trying to develop, 40, 50, 60, 70 different specific antimicrobial medicines that we keep in reserve. So there's not a return on investment on that. So that's why my office has made a priority to help supplement the research in this area. So our priority is to help supplement the research, education, prevention, detection, and treatment. I'm so proud to work with KU Med Center. I'm counting on you all to help me find out what exactly we should be using through research projects, because I know you're not going just to do the research, but you're going to find out the best way to implement it as well. There's something called BARDA up here as part of CDC. So there's different research elements up here that we're working with to try to move this forward. And these are bipartisan approaches. We're working with Senator Dick Blumenthal. We're working with Senator Ben Ray Lujan as well. We have something we're reauthorizing the Presidential Advisory Council on combating antibiotic-resistant bacteria, trying to come up with a national plan to do a laser shot here. Not a moonshot, but this is more of a laser shot on giving you the tools you need to save that patient's life.
We appreciate that. And Hawkeye, from your experience as an infectious disease doctor, I think you feel it because there just aren't that many new antibiotics that have come out.
Yeah, no, you're exactly right, Steve. Like we've said, and you said, the pipeline is very slow and grinding. We see these infections every day. We want better drugs. Certainly, we have some good drugs, but one of our main drugs, and Senator Marshall touched on this as well, fighting MRSA is vancomycin. So vancomycin's been around for more than 50 years. It's a good drug in one sense. It's not a good drug in the other, but we have the technology now to develop research and produce more safe and effective drugs, and the pipeline for that overall, for many reasons, it is multifactorial, has certainly slowed or is extremely slow.
So many new drugs are discovered in universities, and then they're taken over by pharmaceuticals to do the clinical trials and produce them. And what I don't want to see is and so this is why I really appreciate Senator's help so much. You don't want it to be a bigger crisis with millions and millions of people, and suddenly, okay, now we're going to find a lot of drugs. We need to get it before it reaches that point, and otherwise it's going to take a lot of lives, I fear. There is a new drug developed by a team of University of California, Santa Barbara scientists. The study was published in the journal eBiomedicine. Hawk, talk to us about how that drug works.
Yeah, I mean, this is just, one of the new antibiotics, just helping to kill the pathogen, looking for, in various ways, down at the cellular level, things that we've had before, but basically this has shown to be kind of more effective at being able to do that.
Senator Marshall, I think this is the kind of drug development you're hoping to see. Federally sponsored programs that help in universities develop new therapies that pharma can then take and develop and mass produce. Is that fair?
Absolutely. And I think there's 2 points I would share with your listeners. Number one is some of the more traditional drugs that we would use. And I think Dr. Hawkinson should speak to this just for a second about the toxicity of some of those older drugs. I think vancomycin, tropomycin. Talk about the toxicities of those just for a second, if you don't mind, Dr. Hawkinson. I mean, it scares me to death as an obstetrician to have to use some of those drugs because I don't have a Dr. Hawkinson setting in Great Bend, Kansas for a consultation. Gentamicin for that matter as well. And then this particular drug, what the miracle part of this is it attacks a bacteria, I think, through 3 different mechanisms versus the penicillin only attacked the reproduction through one as well. Is that right, Dr. Hawkinson?
Yeah, absolutely. And just as you said, the toxicities are always a concern. So as physicians, we are always concerned, do no harm. And so we want to make sure the benefit of the drug is better than the risk of that. And just like you have talked about with the drugs that you just mentioned, for certain things like that, nephrotoxicity or kidney problems can be associated with some of these drugs. Other things we look at are liver problems that can be associated with some of these drugs as well. And even for your practice, I think it's more important because you are not just dealing with mom, but you're dealing with baby and wanting to keep baby safe as well. And so these toxicities, for just like you mentioned, some of the drugs have significant effects on the kidney, some can have effects on the liver, some may even have effects on the central nervous system or the brain as well. And so we need to make sure, and we always weigh these benefits versus the risk of using these drugs and in what manner, and monitoring that very closely as well.
One thing to say to you, one thing our audience needs to understand, you say, well, I don't have kidney disease, I'll be fine, or I don't have liver disease, I'll be fine, or my ears are good, I'm going to be fine. The problem with these drugs is that often you're giving them in people who are sick, and when you get sick, those bacteria can affect different organs. And then I was an ICU doctor for so many years, and we would use tobramycin, et cetera. And what you end up doing is you end up causing kidney failure. So you don't really want to use tobramycin, but it's one of the best bugs for some bacteria. And so you're into this dilemma: do I treat the patient even though I may cause some kidney disease, or do I not treat the patient but then the infection gets worse? And you're kind of in a difficult situation. So these new drugs are the key to safer therapy and hopefully to helping with some of these resistant superbugs.
And I think to that point as well, if we are talking about drugs like you just mentioned with gentamicin, tobramycin, we know one of the worst bugs, Pseudomonas, can develop resistance to that antibiotic very quickly when it's used as a single drug to treat as well. So we aren't only fighting the potential side effects of it, but back to our topic, we know that these bacteria can develop resistance to those antibiotics fairly quickly if used in the wrong manner.
Senator, one of the problems that we
Dr.
hear
Stites or
about,
Dr. Hawkinson,
please go ahead, Senator.
if I can jump in just for a second. I think just speak to a second about treating cancer patients. Some of these cancer patients have just the worst bugs of all, and we're already compromising their kidneys and livers with the chemotherapy, so it's additive, and I bet that's a challenge with using some of these older drugs as well.
Oh, I think that's absolutely right. And again, these are drugs that have been around for 30 and 40 years. And when I first started practicing medicine approximately a very long time ago, it may have been in the 80s, we may have been in paper. And I remember you would sit there and you go through the list and you say, okay, I've got these antibiotics to choose. And today here I am trying to treat some of those same organisms. I don't have nearly the same number of choices. And I think it's because there's this rise in resistance. We haven't seen new drugs for a while.
Oh, that's completely correct. And I think also, I think that does lend it to working as a team. And we have to give a shout out and give appreciation for our ID pharmacists who work with us here at the University of Kansas Health System as well on a daily basis to help find those best drugs with the least amount of interactions and toxicity to the patients as well, because that is a very important point.
Senator, pharma has appeared not to be as interested in some of these areas and not making as much investment. You've mentioned things we could do together with universities. Is there anything we can do with industry to help with that as well, to help with them? Because we do know it's costly to develop a new drug.
Absolutely. So probably one of my favorite government organizations up here is BARDA. And I think what BARDA does, it tries to work with the private sector, meeting where private sector meets the government, and how we can accelerate that process to come up with better treatments. And then getting the FDA involved sooner and saying, here's a special class of drugs. I need help yesterday on getting this through the process. Of course, we want to make sure they're safe. Above all, do no harm. But there are more expeditious processes. And the alternative for a patient, like you described, with cystic fibrosis that has resistant Pseudomonas, has everything to gain and little to lose by using this drug. So we're trying to push the private sector and BARDA to work together to get these drugs through the process, the research, the development, and then working with someone like KU Med Center to help implement them and do those follow-up studies that need to be completed as well. So that's our mantra up here, is trying to bring miracle cures for people that you're taking care of right now at KU Med Center.
Well, and I think and thank you for that. And I think some of that, I think, as you pointed out, there's got to be a partnership here between industry, academic, and government to help focus and try and help solve this problem. And I think this new therapy that the folks at UC Santa Barbara are talking about looks pretty impressive and also associated with very low level of drug resistance. That's a really big deal to the patients I treat with cystic fibrosis. Chronic respiratory infections continue to be a hallmark of living with that disease because patients with CF have this very thick mucus, and the bacteria love to live in that mucus. And then when things get a little out of kilter, they get too much mucus, they can't breathe. And then you keep trying to use to kill the bacteria to decrease the mucus. The problem is you run out of choices because those bacteria are smart and they begin to develop this severe resistance. We have a video of a woman, Senator, who testified before your committee. She's an adult cystic fibrosis patient who's tried many drugs in her life. Unfortunately, many of them no longer work because of antibiotic resistance. Let's take a listen.
Now in my 40s, the bacteria in my lungs are resistant to nearly every antibiotic, except for tobramycin, which I cannot take because it is so toxic to my already damaged kidneys and hearing. My focus is to manage my symptoms and maintain the best quality of life possible. Without the security of effective antibiotics to help me heal, I find myself living with chronic fear and anxiety about when the bacteria residing in my lungs will act up or when another infection will take me away from truly living.
Senator, you're a physician, obviously, and that's got to be hard to hear from someone testifying in your committee.
Yeah, it is, but I think that's the best thing we can do is tell the story. And Dr. Stites, when you and I were in medical school, I think the life expectancy for cystic fibrosis patients, help me out, 15, 16, 17.
Yeah, that's about right. It was. I remember I first started practice as 17 years old, so not very long.
And all of a sudden, I've got a pregnant woman in my office with cystic fibrosis, and I'm like, what? That was just so unheard of. So now I've got, like Dr. Hawkinson said, now I've got two patients with a kidney infection, and what am I going to do? Or, a pneumonia. Boy, a pregnant pneumonia patient with a resistant Pseudomonas, what a tough situation it is. And I think that this just spells out exactly why we need these new antimicrobials out there. This motivates me to work even harder. I know it motivates you all to work harder as well, to develop new miracle antibiotics that are not as toxic as well. So it's very motivational. I feel very connected to the cystic fibrosis folks back home. So many of them have become acquaintances and friends of our office, as well as we help get them new medicines as well. And again, just to emphasize that what it's like for this patient with cystic fibrosis to be dying from this pneumonia. It is just the worst. It is the worst of deaths.
Well, you just slowly suffocate, right? That's what it really is. It's slow suffocation. You can't breathe, and you can't do things for yourself, and you're 30 years old, and it's a difficult thing. But you're right. These patients are now living much longer. And in fact, some people born today with Trikafta may have a very normal life expectancy, but they will still have challenges, we know already. They will still have challenges with lung infections. They're going to live longer and will still suffer from some of these antibiotic resistance issues. So again, I can't thank you enough for your diligence and your work with this. And Hawkeye, I know you guys work at it every day in the hospital. You try and do a lot of work around infection control and prevent stuff.
Mm-hmm. Yeah, I mean, I think that's the first step as well, is before the patient even gets here, we have those systems and processes in place to help reduce that risk of if that patient has an infection, that infection going, or that bacteria getting transferred to an employee or another patient as well. And so I think that is important. There are many layers of treatment and infection prevention of these superbugs that we do in the hospital every day, and it's done on the floor every day. Everyone from our environmental services who help clean the room to help reduce the colonization and contamination within that room, to the nurses who are at the bedside every day for hours with those patients.
You know what we like to say, the rules of infection prevention control travel with you wherever you go. They'll keep you safe even into this day and every day going forward. Yeah. They still work, gosh darn it.
And we still maintain hand hygiene continues to be the #1 contributor to infection prevention.
Wash your hands, yeah.
Absolutely.
And don't wear ties, that's what you do.
That's right. That's what I do too.
And then, the other thing I think is first aid, gloves, masks, gowns, all that works. Yeah. And we do that, and especially when people are really sick, because you don't want to give them anything. All right, Senator, it's not a problem we can just solve by throwing money at it. What else can we do? We've talked about a lot of things. Anything else you'd like to add to things we can do?
Yeah, I think the one point we probably haven't covered is what we've done to decrease the number of resistant organisms. And I'm going to brag on my veterinarians and what a great job that they're doing, the decrease in the number of antibiotics and when they're using them as well, and different waste management processes. And to be honest, I think human care, doctors, we don't do as good a job as they've done improving in the veterinarian world. So we need to do better education. We need to figure out when and what antibiotic we need to use. I still see a lot of misabuse of it. I think it's improving. I think that it's improving. We've educated orthopedic surgeons, and we know how hard that is to do. We've educated them on when to use antibiotics and how to use them. But I think, just in the ER setting and the primary care setting, and thinking that every person that walks in the office needs ampicillin just creates a tough world as well. So I appreciate the education that we try to do, medical school residency, but need to keep working on that as we see additional primary care doctors and particularly nurse practitioners and PAs coming online. It's really hard to tell that mom, look, I know your son has the sniffles, but this is a virus. Can you just give it 24 hours before we give you another prescription of ampicillin or erythromycin? Meanwhile, up here, I'm doing what I can to work with the FDA to make it more streamlined, working with the CDC, NIH, to empower people like you all in KU Med Center to do a better job of delivering care for Kansans.
And thank you.
Yeah, and I think that point that the senator just made is vitally important. So practitioners, physicians, APRNs, nurse practitioners may know the right thing to do, but it is definitely hard to look at that patient or that patient's parent in the eye and say, look, this is probably more than likely a virus. More than likely. You won't need antibiotics. They will not help you. But to be able to stand your ground and be able to not give that is very difficult in that interaction in that exam room.
Well, especially somebody could just leave that and go to their CVS mini clinic or someone else. And we do have to make sure we try and uphold those standards. And that's why antibiotics cannot go over the counter. You've got to keep them as safe as possible and try to decrease their resistance. And we have to have, the only thing I would say is constant vigilance. You know, a few years ago, there was a problem with fertilizer because Burkholderia cepacia was occurring in fertilizer to do yard work. And so CF patients doing yard work and getting Burkholderia cepacia from the fertilizer. And so it's a terrible bacteria in CF, and that's, we got to have constant vigilance. The center is absolutely right about the work being done in veterinary medicine to try and prevent, and again in fertilizer and feed and things like that to try and decrease resistance, and then all the work we have to do in medicine. Okay. We're here to answer your questions. Send them in to the information on your screen. That includes YouTube, Facebook, the X platform, or emailing the Medical News Network. While you send in your questions, we're going to get a check on our COVID numbers today with Doc Hawk.
Yeah. So right here in the health system, we have 17 active infections this week. Numbers very good compared to what it was last week. So I think hopefully we are reaching a plateau, at least a temporary plateau, or even a continued decrease over the next few weeks. We know we just had the Thanksgiving holiday where people were probably together in groups, family, friends, loved ones. So hopefully the hospital admissions will continue to stay low, but we know the virus is still circulating out there.
Yeah, you know, we went from 15, 16, 17, 24 last week, and then 17 again. So I think it's where we're going to run.
Yeah,
we'll have to see where Thanksgiving takes us, but this is certainly a far cry from where we were 3 years ago.
Yeah.
Thank God Almighty, because that was not so great. So Hawk, a little bit of things have come out about maybe we need to cause antibiotic resistance or antimicrobial resistance with a cooler term than that, because that's just a mouthful. So talk to me about what you think about being cool here.
I mean, being cool is always good. I think what we need to do...
Are you on TikTok now?
I am not on TikTok for various
Senator, are you on
reasons.
TikTok? I am not on TikTok.
No way. Don't get me started on China, okay? Don't get me started on China and TikTok. But hey, I do got a quick question for you all. Do you know if the protein-based COVID vaccine is available in pharmacies yet? I'm just excited about seeing that one hit the market. It has probably a little bit longer lasting effect based on what I'm reading.
Yeah, we know it was delayed compared to the mRNAs. I don't know that it's available just yet, and I don't believe we have it in our health system just yet. There was just a little bit of delay of that rollout. But I think you're right. I think it is a great option for people who, for one reason or another, do not want to take the mRNA vaccines.
And Novavax, is that another?
Novavax.
Yep.
That's it. Yep.
That's it.
Yeah, so we've had Novavax here before. I've given some patients Novavax. I don't know if their most recent update. I think they're a couple of weeks behind, but yep. But it'll be out, and Novavax is a really good, is a great therapy. If you look at the data, it looks really as good as mRNA vaccine, so it's good stuff.
Yeah, and if it's one more thing to help reduce, especially those at highest risk of hospitalization and severe disease, I think it's a good option.
Hey, I want to check in with Dr. Jennifer Hartwell. she is the Chief of Emergency General Surgery here at KU. We want to talk about a breaking medical news event. Late Show host Stephen Colbert had to cancel a few shows after his appendix ruptured 6 weeks after which he had COVID. So the question is there such a thing as COVID appendicitis? Dr. Hartwell, I know there's COVID. I know there's appendicitis. Is there COVID appendicitis?
Great question. There's a little bit of science behind why maybe there could possibly be a higher risk of appendicitis after COVID, but the data is not strong enough to put those two things together. So in our practice, we treat patients with appendicitis, we treat patients with COVID. We'll treat and look for disease processes based on people's presentation, but not necessarily associate them. So if you get COVID, we're not necessarily waiting for your appendicitis. It's not that strong of a correlation.
So what you're saying to me is that if I get COVID, I'm not going to necessarily have to come see you just because of that.
That's right. You will not necessarily get appendicitis. We're happy to treat you if you do, but we're not on the lookout for it just because you would have had COVID.
Yeah, and patients do get appendicitis even without COVID, huh, guys? So I'm kind of doubting that correlation here. I don't know.
Yeah, no, I think I would absolutely agree. You know, since 2021, there have been some case studies. So that means maybe at a single center, like a single hospital, or multi-center. There have been some case studies where they put several cases together of people that have had appendicitis and recent COVID. So I think I would absolutely agree there's no real causal relationship. Is there maybe an increased risk factor? That could possibly be, but the numbers are so small there is no direct correlation. And so I would just agree with Dr. Hartwell in saying that if you have COVID, I wouldn't necessarily be worried that you're automatically going to get appendicitis or anything of that nature. No specific COVID appendicitis. I think it's a good question and it needs to be answered. We know we have seen COVID do many different things, both in the acute infection, but also in that long COVID as well. After that acute infection gets resolved, but I think there isn't really enough data to support the fact of, like you said, COVID appendicitis. Is there a possible increased risk several months out after that acute infection? That is a possibility as well, but I think we still need more data.
All right, all right. Alexis tells Sid, you've been watching for questions from our community. I'm going to bet we have a few today.
We have some really excellent questions. Yen Liang, who's one of our viewers, wrote on Facebook, and this is such a good question. My husband and I were actually just talking about this morning because it was on the news. It led the news. Yen writes, is the current prevalent mucormycosis infection in mainland China likely to turn into a new wave of a pandemic, leading to a repeat of global lockdown measures?
Okay, let's not go there, I hope.
Hawk? Yeah, what was it? Mucormycosis?
Mucormycosis. I don't know this mucor.
On the news, they were calling it pneumonia. I don't know the medical term.
There's been a rise of infection that looks to be some type of viral-related infection that's been occurring in China. It's pretty early, and I don't know. As typical, we don't get a lot of clear information coming out of it.
I think I would agree with you on that, and back to Senator Marshall's earlier comment. But yeah, I mean, I think what it was is maybe an increase in pediatric evaluations at the hospital. And again, their hospital system is a little bit different as far as what they consider going to a hospital or an ED. So I think there was an increased rise in that. I don't think there's been any firm data on what that was. Is this just a catch-up now after the lockdowns have been lifted in China, as we had seen and other countries have seen and written on, particularly like I know Australia did that in RSV when their RSV season was a little bit delayed from what it normally was, so they saw an increased rise. So is that what this is? We suspect that's probably what it is just a delay in the normal cycle of things because the lockdowns were recently lifted. Yep. And so I think that's what we're seeing and we're believing. But just as we said, there's probably not a lot of information exactly what that is. I don't think there's any indication right now that there is a new global pandemic.
Senator Marshall, have you heard about that as well?
Yeah, if I could just give a quick comment. So number one is we're scheduling a phone call with the CDC with the Doc Caucus. The Doc Caucus is a group of physicians up here that are now serving in the House or in the Senate just to get an update. I think most likely what this looks like is a lack of immunity. That for the past year or two, we've kept our kids separated. We haven't had as much of infection. Certainly, China did the same thing, and now we're having a big rebound. And I think we even saw some of this happening across the United States as well. Like you said, the RSV was a little bit later. So I'm not going to overreact. And the biggest difference between today versus what was going on with COVID in January of 2020, when I asked the CDC to have a phone call with me, they said, but they delayed it, and then they lied to me. And basically China was very much hiding everything. There would be absolutely no communication from them, and we're being deceitful. So it looks like right now that China's being, relatively for them, forthright with what's going on there. But I do want to ask the CDC what is going on, not take anything for granted, and we'll keep you all posted, I promise you.
Yeah, thank you. And I'm going to bet it is this thing. We see this in other areas where people have been isolated for a while, and then there is a rebound infection. And clearly COVID is a great example of that. It's probably not the only example as you look back through other pandemics and epidemics in human history. So,
Jeremy Yenser has an interesting question. Jeremy writes, have there been any successes in altering existing antibiotics to overcome resistance, or is the focus mainly on discovering new antibiotics?
So, Huck, we've modified a lot of antibiotics. I think
yeah.
about many of the drugs get a little modification, and that buys you a little more time.
Yeah, I think you're exactly right. You know, a lot of the drugs that we have right now are built on backbones or science from previously identified and used antibiotics, and I think there are those modifications that have gone on. But we also want to identify, just as this other new drug, identify and look for novel new compounds that affect the bacteria, virus, or fungus in a new way as well. So there's the combination of those things.
Yeah, and I think one of our challenges is that a lot of these old drugs have been modified, and they keep getting modified.
Yep.
But I think we're running out of modifications
Absolutely.
to make, and
Yep.
after a while, you can't change it because the base most of the modifications don't really change the base mechanism for how they cause disease. And when a bug gets really resistant, it can usually defeat
Yep.
those modifications.
Yep.
Joellen McGranahan has a question about Big Pharma. Joellen writes, everyone has heard about Big Pharma, but is there a small pharma that could research, or has it all become too much?
So, Senator, your thoughts, and then I'd like to chime in, because I think people underestimate the importance to your earlier thoughts about the academic universities and what a big part of the research powerhouse they are.
Well, look, the base of research being done out there is by a lot of small companies on a 1,000-to-1 shot, and 95% of those that are involved in the antimicrobial business are going broke right now. And then what happens is a big company like Merck or Pfizer then buys up those patents for the successful ones. But the supply chain is my problem right now. This number of small companies out there that are typically entering the market cannot get venture capital. And I'm going to get political here for a second, but this is why. When the federal government starts putting caps on medicines and what they can be reimbursed at, then all of a sudden venture capital says, my gosh, we're not going to be involved. And that's why I'm working hand in glove with my good friend, yes, I said good friend, Bernie Sanders, trying to solve this dilemma. That we certainly want to drive the cost of prescription drugs down, but we don't want to kill innovation. And that's why we need to come back and do a show on pharmacy benefit managers. But we'll do that another day.
Well, I would love to have that program. Trust me, man, we'd be all about that one. And then, you know, the other thing I would just say is that when you look at new drug development, about 60% of novel therapies come out of universities. The challenge is that, to the senator's point, a lot of times then you take those and it's a small pharma or a small pharmaceutical company or startup company that will take that and try to develop it. And if you don't have someone out there to help back it, then they can't get those drugs developed. You know, that is the story of cystic fibrosis. CF was really developed on the backbones of the therapies for the backbone of the Cystic Fibrosis Foundation, who raised the money to give to universities to do research, and then the CF Foundation helped do startups. Because they help fund those startups, because there wasn't a lot of other funding available, to the senator's point. So, you know, we're all in this together.
Yeah, and I think to your point, I would like the senator's comment on this as well. You know, the United States FDA is the premier organization really in the world, and a lot of other countries look to our FDA for being able to evaluate and approve new drugs. And so this costs money. This costs money to develop first the compound and then evaluate it in the trials and looking for safety and effectiveness. And so a lot of it is resources as well. But I think what my point is that the public should know and understand that the FDA is working very hard and diligently to make sure that the drugs that you get, number one, are effective, but more importantly, are safe as well. And that costs money to do those trials and get that data and report on that data as well.
Yeah, I think simply put, if you think of a young startup company, they have 100 different drugs that they're working on. One of them comes to fruition and at KU Med Center, and they sell that patent to Pfizer, it'll still take another $1 billion and 10 years to get that through the FDA process. And I think certainly I think we could get the safety part figured out in 2 or 3 years. And again, they would come back and do that research, say at KU Med Center, to prove it's safe. The efficacy is what's harder to bear out as well. So we are trying to work with the FDA to make sure we maintain the safety, but streamline that process somehow, some way. It's a big challenge. You err on one side too much, and you get an Alzheimer's drug that was approved too soon, and you err on the other side too much, and no Alzheimer's drug ever gets approved, or in this case, an antimicrobial miracle medicine as well. So it's a challenge. We're trying to find that sweet spot.
I think that's exactly right. I think one of the challenges we face is if we try to go too fast, and then we don't do enough testing in patients, and then we find out that there's this side effect that we didn't know about, and then you're stuck. And so there's this balance. You got to try work to your best to achieve that. Alexis.
Jan Vineyard has a question. She wants to know, are there any new medications to fight MRSA?
New therapies. I mean, we have a rivacycline, that's been a new therapy. There's other new ones out there.
Yeah, there's a couple new cephalosporins. There's always things that are in development, nothing on the market just yet. I mean, right now, our best drugs to fight MRSA continue to be vancomycin, linezolid, daptomycin. There's a couple others we can use as well. But nothing other than that is new that we would use. We still have our same go-to traditional meds.
And again, that's because there aren't new classes of antibiotics that have been developed.
But I would say for certain infections, MRSA can be treated with several old drugs as well, things like Bactrim, things like doxycycline. And so we really have to tease that out. It's really those severe infections that we always want new, more safe, more efficacious drugs.
Some of the strep infections that are this particular resistance get very concerning to enterococcus.
Absolutely. So I think all of those things, and most of those drugs that would probably treat MRSA will also probably treat the strep infections as well.
Senator.
Okay, we have one more question.
For Dr. Hartwell. So let's say my parents had COVID last month and they have belly pain. Explain to your listeners, when should you be concerned about going to the ER? What's the difference between just general gastritis versus, okay, I need to go to the ER? I think regardless of what we're going to talk about today, to reassure folks, I know that my office back home, that they're going to be calling my nurse and say, my gosh, I had COVID, and now I got some pain up here by underneath my heart here. Can you just talk about that for a second?
Yeah, absolutely. Thanks for that question. So patients who have appendicitis or problems with the gallbladder or things that would warrant a trip to the emergency department usually have things like fever, nausea, vomiting, pain that doesn't subside, pain that gets worse. Some people describe it as the most severe pain they've had. Pain that's in the lower abdomen on the right side is pretty typical for appendicitis. Pain kind of up on the upper right side is typical for the gallbladder. So I would say I would advise my family members, if they have a fever, pain, nausea, vomiting that just isn't abating, to come on in and get checked out.
And a simple thing I always add is just call your primary care doctor's nurse if you're concerned before you go to the ER. Just ask them, hey, I got this pain, and every time I eat, I get pain up in the right upper quadrant here, and it doesn't go away, and it's worse when I eat fatty foods. So that's an easy one, right? But the appendicitis typically is kind of a generalized abdominal pain that comes, it eventually ends up in your right lower quadrant, but there's almost always a fever. I mean, I can't ever remember a person having an appendicitis that didn't at least have a low-grade fever. Maybe that's not your experience, but the low-grade fever is the important tip here.
Agree. And not wanting to eat anything, loss of appetite, nausea, vomiting, those are concerning signs, and calling the doctor and getting some advice is a great idea.
And appendicitis tends not to be the most subtle thing in the world. It's more like a truck.
Again, I've never seen a patient with appendicitis that said they wanted to eat. They're never hungry. They've got a low-grade fever. Yep.
That's pretty. Okay, Alexis, one more question, I think.
Two more questions, because we just got an email from Susan. This is a really active program we have on. Susan wants to ask Dr. Marshall, can you please explain BARDA? What does BARDA stand for, and what is their mission?
Great question.
Charlotte, help me out here. Charlotte, come on over here. So Charlotte Panetta is my ACE healthcare staffer. Tell them, I don't even know what BARDA stands for. So come on in here, Charlotte, come on in.
Yeah. Hi, BARDA stands for the Biodefense Advanced Research Development Authority. It's under ASPR, the Assistant Secretary for Preparedness and Response at HHS. And again, it's that arm in the federal government that really enables federal, private, public partnerships to bring products to market sooner.
So Charlotte is,
Don't worry, I could have said that. No, I couldn't.
She's my head nurse here. So what does BARDA do? I mean, what did they do during COVID? They did a couple really miracle things.
Yeah, so Dr. Marshall, as a member of the Doc Caucus when he was in the U.S. House of Representatives, worked very closely with a former initiative called Operation Warp Speed. And BARDA led an initiative that helped to fund research and development and really go through some of the more tedious processes that very small companies just don't have the prowess to go through in working with FDA, in working with the U.S. Patent and Trademark Office, in working through different zoning requirements and things that really are necessary in getting a product from the clinical trial aspect to the approval aspect to actually in the pharmacy and in shots and arms.
Charlotte, could KU Med Center come up and visit BARDA someday? Do they work with universities?
Yeah, universities play such a pivotal role in bringing products to market because pharmaceutical manufacturers and small tech innovators heavily rely on teaching academic hospitals such as KU at Doc's alma mater to run their clinical trials.
She's good.
So, we're actually, we do participate in those things. We do love to visit, by the way.
Yeah, that'd be great.
It would be fun. And maybe we do a program from BARDA. That'd be cool.
Charlotte's incredible. Loved hearing from her.
Last question.
Jenny has a question. So many moms are going to want to hear the answer to this, okay? Jenny writes, my son always gets ear infections. I have a friend who told me I should just let the infection run its course instead of asking a doctor for antibiotics. Can you let an ear infection just run its course?
Hawk.
So my big caveat is I am not a pediatrician, but what I would say is that every individual case needs to be evaluated by that pediatrician. I think it would be very dangerous to just let an ear infection run its course, especially if it is a bacterial infection, things like strep, Pseudomonas, but I think most common in children are going to be staph and strep. And certainly we know with strep you can have things like rheumatic diseases after that. So I think that would be a very dangerous thing to just let the ear infection run its course, as you will. I would certainly advise, because we know kids have they can have multiple ear infections in a very short time period, and maybe they need tubes, maybe they need some intervention by an ENT or an ear, nose, and throat doctor as well to help reduce their chance of further infection. But we don't want things like systemic illness or deafness, so I think the best thing is to go see your pediatrician, get evaluated, and if you need antibiotics, get on antibiotics.
Yeah, family medicine doc,
Absolutely.
care physician, whoever that may be. And I'm going to bet Senator Marshall that even though you're an OBGYN, you're in rural Kansas, I bet you treated some ear infections over the years.
Oh, absolutely, and I had kids and grandkids. Look, this is why we went to medical school for 4 years, and we did residency for 3, 4, 5 years. You've seen one child, you've seen one child. This is why you need to go see a doctor. Every once in a while, you can't do everything through telemedicine. We have to look in the kids' ears. It scares me to death. I mean, again, our ER doctor, you've seen this person that had an untreated ear infection, and did it turn into mastoiditis or meningitis? And I don't want to scare people. I do think that the ear infections are overtreated. Being treated for an ear infection over the phone scares me a little bit. I think it's when we use too much antibiotics. But this, folks, is why we went to medical school, was to sort this out and just figure out if they need antibiotics or not. And it's so good when you have your own doctor that knows you, that knows your kid. This is so important just to be able to sort this out. So ask your doctor, right?
Yeah, I think that you never know what the rest of that kid's history is, right?
Yeah.
Are they diabetic? Do they have a malignancy, whatever? And there are all these things you have to weigh in to make those decisions. Actually, there's some pretty good treatment algorithms now that are pretty predictive for ear infections and which direction to go, I think.
And I would say, too, that when we are talking about most of these things are viral, 80% are viral, this is not the ear infection that we're talking about. These are more upper respiratory cough and cold symptoms, maybe a little sniffle, maybe a little sore throat, cough, fever. That is not the entity of the ear infection that we were just talking about. Most of those upper respiratory symptoms that people are having, especially during now, are more than likely going to be viral rather than bacterial.
All right, this has been a great program. We can go on for a long time, so please, Senator, you'll have to come back and be a part of this program again, including your staff. They're awesome. But let's go around the table and get final thoughts. Senator, I'm going to start with you.
Hey, it's all good. Thanks for having me. I just so appreciate my alma mater. KU Med Center saved the life of my father and my brother in the past 2 years. And just so appreciative of what you're doing out in Great Bend and across the state. A leader in research in so many ways. Kansans can be proud of the University of Kansas, and I'm just so proud of my alma mater. So thanks for having me on today.
Thank you, and thank you for helping lead the fight against antibiotic resistance. Truly, that is a deal very close to my heart. Senator Hartwell, good gosh, Dr. Hartwell.
Good.
Do you have a political future? I don't know.
I guess I do now. Well, thanks a lot for having me. It's always great to get some good information out there so patients and families can be reassured about things that maybe they're hearing in the news. So thanks for the opportunity to come on. We're always here to help.
Dr. Hawk.
Yeah, great discussion. You know, antimicrobial resistance is something we deal with every day in my practice, so I think it is vitally important that if you have an infection, please go visit your physician, go visit get evaluated by a medical team. It is vitally important just to understand, do I need antibiotics or do I not need antibiotics? Because we want to use antibiotics when it's the right circumstance, when it's the right situation. But if it's not, we don't want to use them. And using them in the wrong situation can certainly lead and has led to increased antimicrobial resistance, not only in our community, but throughout the nation as well.
You know, we talk all the time about the intersection of faith, hope, and science. This program has just illustrated again. You have to have faith that we're trying to all work together to do the right thing, hope when we're in the hardest of times, and the impact of science to help deliver us new therapies. But it does take all of us. It takes all of our folks out there in the community who try to remember that not every infection needs an antibiotic. It takes all of us with working hand in hand with government and university and academic and pharma to try and develop these new therapies to make sure that we can deliver on the promise of those drugs to continue to treat infections and help make sure people don't die from things we should be able to treat. Thank you so much for being a part of this program. We'll be back next week.
Alarming and dangerous, unusually strong words from the CDC as cases of syphilis infection surge in newborn babies. I'm Alexis Del Cid. On the next All Things Heart, we look at the dangerous heart complications that can come with these preventable infections.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.